Thank you, Dr. Parveen and Dr. Anu, for including me in this keratoconus instruction course. And I'll be talking on corneal transformation, advances in the management of keratoconus. So as Dr. Sharon was supposed to present surgical management and DALC, so I'll be starting from her talk. So I frequently do femto-DALC in all my keratoconus cases. So we have Zimmer's Z8 machine. So this machine has a proprietary DALC software. So in DALC, the main challenge is to get a big bubble because you're not sure whether you will get a big bubble or not. So with this software, what you can do, this has an intraoperative OCT also. So you can take a picture of the OCT during the surgery and create a tunnel in the posterior stroma, depending on the thickness. So like we have removed 350 micron of the cornea, and then from the remaining cornea, you can go create a tunnel and go up to 30 micron. And once the tunnel is created, now the surety of getting big bubble is very high. So just see this video. We have cut the cornea, stroma, and this is the tunnel created by the femto laser. And once the tunnel is created, you have to use Foglas cannula to inject the air in the tunnel. And the procedure becomes very simple and predictable. So you have to go inside and inject the bubble. And success rates are very high with the femto-DALC, and then suturing is done. So coming to the next procedure, that is stromal expansion. So in keratoconus, the main problem is thin cornea, problem in contact lens fitting, and cornea not fit for cross-linking, so you cannot stop the progression. So in such cases, stromal expansion is a wonderful technique by which you can tame all these three problems. So this is a Visumax machine on which you can do this procedure. It's as similar as smile surgery. You have to create the lenticular pocket, remove the minimal stroma, which is because you have to remove something, so at least 10 or 12 micron, remove it. And this is the donor lenticle, donor smile lenticle from the patient. So usually I prefer to use at least 120 or 130 micron donor tissue, and simply you have to push it inside. The procedure is very simple. There is no learning curve. You have to push up to the extreme opposite end. It should not come in the wound. And once you make sure that it is nicely settled, unfold it, and the procedure is done. So you have added the tissue. Now the next goal is to do the cross-linking in such cases. So once it's done, you can gently peel off the epithelium because the tissue is very soggy. You can remove it with the simple sponge. You don't need to use the knife. And you can see how easily it is coming out. And once that, so there is a nicely sitting lenticle inside, so you have increased the thickness. So now it's a thicker cornea, and you can do the cross-linking, so it won't progress also. And it induces flattening also. So the post-operative best corrected visual acuity also improves, and contact lens fitting also becomes easier. So this is a post-operative picture. The lenticle is nicely sitting, no haze in the stroma. Coming to the next treatment option in keratoconus is the topo-guided PRK with cross-linking. As we know, the cross-linking is the standard of treatment for preventing the progression of keratoconus. So if we have good preoperative thickness in many cases, so we can combine with the topo-guided PRK. So by this, we are flattening the cornea, we are removing the aberrations, and as it is topo-guided, the aberrations will be less, and you can reduce some cylindrical error also. But the limitation is that you should not go beyond 50 micron ablation. So in 50 micron, you can reshape the cornea as well as reduce the astigmatism. So by which you can get the good visual acuity along with the keratoconus progression arrest. And the protocol is that expected corneal thickness after this procedure should be at least 400. You should not go beyond that. The next augmentation procedure for keratoconus eyes are intact rings or intercorneal ring segments. So these are the PMA segments, and it comes in different sizes, and you can combine based on your need or on the patient's profile, cornea profile. So it basically works on the principle of arc length shortening. which means the outcome is directly proportional to the thickness of the implant. So if you put thicker implant, the flattening will be more. It comes in two designs, regular rings or SK rings. And these are the prerequisite for intacts in keratoconus. The first, the central cornea should be clear, because if there is an apical scar or a haze in the center, you won't get good visual acuity. Contact lens intolerance. So the first option is always contact lens, as Dr. Anu mentioned. But if we are not able to fit the contact lenses, and because the cornea is very steep, you can flatten it with the intacts and then go for the contact lenses. Results in very steep corneas, more than 60 micron, more than 60 diopter, the results are not very predictable. So the best patients is from 52 to 58 diopter range. And the last is pachymetry should be more than 450 micron in the location of intact. So location is usually 6 to 7 millimeter in the cornea. So in that area, at least you should get 450 micron thickness. So these are some of the parameters for planning intacts: location of the cone, mean refractive spherical equivalent, mean K value, superior inferior asymmetry, steep axis, and the thinnest point in 6 millimeter zone. So these are the protocols that we learn at Narayan Netralaya from Dr. Rohit, and we plan our intacts ourselves. We don't rely on the company's nomogram. So the locating cone is very simple. Just you have to see the steep point. If it is in the central 3 millimeter, it's a central cone. If it is outside 3 millimeter zone, it is a decentered cone. The next is MRSE. The spherical plus half cylinder gives you MRSE, and based on MRSE values, you can choose your rings. The mean K value is here in the pentacam, and if it is less than 55, then regular rings works well, and if it is more than 55, you can go for SK or thicker rings. Superior inferior asymmetry. So difference. So how to calculate this point? If the difference of mean of superior 3 contiguous points in 3 millimeter zone to diagonally opposite 3 millimeter zone, if it is more than 15 diopter, then you should use single ring. If it is less than 15 diopter, then asymmetric rings works very well. Again, the axis location from where you should insert your intact rings. So it should be at the steep meridian, OpScan, pentacam. You can use any device. And sometimes with the OpScan or these topography, they shows the steep axis nasally or inferiorly. So in such situation, you can go for tangential method. So how to find the axis and the tangential method? You have to draw a line towards the direction of the cone and then draw perpendicular to that, then you will get a steep axis. Incision depth, then mark the 6 millimeter zone and take the 75% of the thinnest pachymetry at 6 millimeter zone, and that will be the plane in which you are going to put the intact strings. So these are some of the instruments used for intacts. So I prefer to use femto intacts because many people are now doing femto only, and you have to create a channel with the femto machine. This is a Zimmer machine, and once the channels are created, you have to open the channel. So this is a channel opener, which is V-shape. You can open both the sides with the same instrument. You have to go vertically first and then horizontally along the cornea plane, and then you have to insert the rings. Inserting rings is very easy. The problem is holding the rings because slippage is very high with the intact rings. So you have to be very careful. You should not hold very tight and not very loose also. And always push the ring towards the opposite extreme. Never leave at the wound because it can migrate out. Okay. So these are some of the cases in which we have put intacts. So you can see there is a central cone. We have put 2 symmetrical rings, and from 55 it is now 44. And the K1, K2 decreased from 59.5 to 55.8. Almost 4 diopter flattening was induced with this intacts. And this is a decentered cone case in which we put a single ring, and you can see the flattening from 47.4 to 44.3. Again, 3 to 4 diopter of flattening. This is a asymmetric cone in which we put the asymmetric ring, and flattening from 44.2 to 41.4. Again, 4 diopter of flattening. So intacts is always combined with the cross-linking procedure, and because cross-linking arrests the progression of the keratoconus also, and it induces more flattening with intacts. Intacts is flattening, again 0.5 to 1 diopter. Cross-linking is also flattening, so the result will be better. And although it has some complications, like vascularization of the incision site, melting at the incision, you have to put sutures in that case, deposits along the intact rings, which usually improves with the steroids. And so this was one case I did last month in which there is a Kerr ring inside the eye, and you can see the vascularization and melting along the intact ring. So I removed this ring and then treated the patient topically, and eventually the patient heals. So we have to be very careful while managing these complications. And this is again another case in which the ring has migrated outside the incision, and it needs to be explanted. Explantation is very easy again. You have to take a dialer or any such instrument and put in the dialing hole and take it out along the direction of the placement of intacts. So it's removed like this. So the new thing in keratoconus is the CARES, done by Dr. Susan Jacob mainly, and this is a new innovative technique in which instead of using plastic ring segments, donor corneal tissue strips are inserted in mid-peripheral zone of keratoconus cornea to cause its flattening. Although this is a very good technique, but again, because this is a corneal tissue, so risk of rejection, risk of infections are higher than the intacts. And as these segments are more biocompatible and less rigid in comparison to plastic ring segments, so we are not sure after 5 or 10 years how they will behave, whether they will flatten more or the effect will go off. And the main difference between intacts and CARES is that intacts is a reversible procedure. You can remove the intact segment if you don't get the good results or anything happens. But with CARES, it integrates so well with the cornea, its removal of CARES is almost impossible. Thank you so much.
Thank you, Dr. Bhupesh, for an excellent